Good evening everyone. So I hope you have gone through the part 1 of this video. I will be releasing both of these videos simultaneously together so that we can have a good understanding about the process of pruritus. Okay, and that is actually important. In the first part of the video, what we did was we understood the physiology of pruritus. That means how does the signal of itch gets elicited on the skin surface, travels through the free nerve endings, the cutaneous nerves, goes to the spinal cord, has some kind of manipulation and modulation by the interneurons, and then ascends the spinothalamic tract, reaches the thalamus, and undergoes central processing. So this is how itch is mediated to the from the skin to the higher centers in the brain. We also talked about a lot of mediators, namely histamine, substance P, cowhage, and neurokinins, different receptors like TRPV1, TRPV4, and neurokinin receptors, opioid receptors. So we had a good understanding of the physiology of pruritus. Now what in this part, the second part, what we're going to do is discuss some clinical aspects of pruritus. I will not concentrate more on the treatment of pruritus per se. In other words, I will not be able to tell you the regimen and doses. Of course, the reason for that is that every treatment is patient specific. Okay, you have to, as a dermatologist, you have to decide what drug has to be given in which cases, whether you would like to modify that as per the renal or hepatic status of the patient. We are going to discuss the specific clinical scenarios in which itching plays a major role and what is the mechanism of action of the itch pathway in those scenarios, and what all different ways of presentation of pruritus could happen. How do we classify pruritus? What are the different types of itching? What is the itch scratch cycle? So these are the things that we are going to concentrate on, that aspect in this part of the video. I would request you to first go through the part 1 of the video to understand the basic physiology, and then come back to the part 2 to understand the clinical aspects. It will be much easier for you to grasp the concept of itching, and then if we know a lot about itching, we'll be able to control this very important, very common symptom in our patients. Now we'll start with the presentation on the clinical aspects of pruritus. Now this is the classification of pruritus. Okay, so various techniques have been devised to classify pruritus. One is time based. That means you have chronic itching which lasts for more than let me just write it again, more than 6 weeks, and acute pruritus which lasts less than 6 weeks. So this is more of a time-based division of itch. This table, the table that I'm showing right now, divides or at least attempts to divide itching into different causes, or different, you could say not exactly causes, but the different pathways through which that itch cycle gets activated. Okay, for example, the first part is pruritoceptive. That means in this pathway the pruritogens or the pruritic receptors gets activated. Okay, so it originates in the skin and is transmitted to the CNS through the first, second, and third order neurons. Okay, so this is the pathway, the normal pathway, the normal itch pathway, which starts at the level of skin, and the signal goes through the free nerve endings, the cutaneous nerve, spinal cord, and the brain. Some examples include urticaria, insect bite hypersensitivity, mastocytosis. This is majorly mediated by the itch mediators, most commonly histamine. We have discussed in detail the role of histamine in itch. If you want to go through it again, you should look at the video on first generation H1 antihistamines, in which we discuss histamine. We also discuss it a bit in the part 1 of this video. The second classification is neuropathic. Neuro means nerve, pathic means disease. It occurs due to neural injury or injury to its specific areas in the brain. The examples include notalgia paresthetica or brachioradial pruritus. Now, what is notalgia paresthetica? So, many a times the thoracodorsal nerves or the nerves originating from the spinal cord may get damaged or compressed. This is mostly seen in elderly. It can be because of nerve compression, or the most common nerve you could say the most common viral infection causing nerve disorder, the herpes zoster. So after the infection by the herpes virus, a significant amount of patients will have some form of neuralgia. Mostly it is pain, but they can also have itching as a presenting and prevailing symptom, and it leads to changes in skin, leading to a chronic itch, which is situated over one side of the back or maybe over the areas previously affected by herpes. So that becomes notalgia paresthetica. On the other hand, the brachioradial pruritus is the same mechanism, but it occurs on the extensor aspects of the arm, and that is mainly because of the compression or damage to the cervical nerves. So there's no problem in the mediators, there's no problem in the receptors, there's no problem in the free nerve endings. But the problem is in the nerve carrying the signals. Okay. The third part is neurogenic. Neuro means nerves, genic means originating from. It's a centrally acting itch without any damage to the neural networks. That means centrally acting means that the brain is involved. Okay, brain is involved and the nerves are okay. Nerves are okay. So in neuropathic, the nerves are involved. Okay, while in neurogenic, it's the CNS or the central nervous system or the brain is involved. Okay, mostly it is seen in, you could say, opioid dependent itch, not dependent, but caused by the opioids. Now, opioids we have discussed in the part one of the video that mu receptor opioids, when activated, will cause itch. Kappa receptor opioids, when gets activated, will decrease itch. Okay, so these are opioid receptor based itching. The fourth is psychogenic. That means it's related to psychiatric disorders. In relation to psychiatric disorders, which the most common is the delusion of parasitosis. In this, the patient would feel that some insects are crawling in the skin or there is some kind of deposition in the skin, and it leads to chronic itching behavior and scratching behavior of the patient. It can occur in isolation or can be in association with other psychiatric disorders like schizophrenia or depression. Okay, so the examples of psychogenic itch include delusion of parasitosis, psychogenic excoriation, somatoform pruritus, and other pruritus which are associated with different psychiatric disorders, depression being one of them. The fifth is mixed, in which there are multiple causes. Okay, for example, if a patient has depression and is not taking care of themselves and the skin is now infected, that can cause pruritoceptive itch along with psychogenic itch. So when multiple types of itchings are in one single patient, you call this as mixed. And idiopathic means that all other parameters you have checked and evaluated in the patient and it does not lead to any positive results. You're not able to find or at least locate the area which is involved in causing the itch. So you have to term it for the time being as idiopathic till you evaluate further and find the cause of itch. So I hope it has been clear. There are major four categories: pruritoceptive, neuropathic, neurogenic, and psychogenic. The fifth one is mixed, which is more than one, and sixth is idiopathic, in which cause is not elucidated. We'll discuss the itch scratch cycle now, and itch scratch cycle is very important, especially in chronic itching disorders. Okay, chronic itching disorders. And multiple times when patients come to us, they have an itching disorder which is much chronic in terms of duration. So whenever a patient is suffering from a disease which is very itchy in nature, they tend to scratch a lot. The scratching leads to release of more inflammatory mediators, and because of release of inflammatory mediators, there is increase in itching, and increase in itching will lead to increase in scratching, and there it becomes a vicious cycle. Okay, so you start with a little bit of itch, which leads to scratching, and then scratching leads to itching, and this is a vicious cycle, and this is known as the itch scratch cycle. So whenever you're treating any patient who is complaining of chronic itching, you have to make sure that you have to break this cycle. The cycle has to break. You will help the patient will do much more of the efforts to break the cycle. They have to be educated that this cycle has to break, otherwise chronic skin damage may occur, and because of chronic skin damage, you're releasing a lot of inflammatory mediators, thereby increasing the propensity of itching. Now I have highlighted roughly 8 reasons through which chronic itch cycle or the itch scratch cycle can occur. The one first is loss of inhibitory control. Now remember, in the first part of the video we discuss about various negative feedbacks of the system, which include interneurons and various receptors which are supposed to depress the signals of itch coming to the brain. So if that inhibitory control is lost, you have a loss of inhibitory control leading to chronic itching, chronic scratching. Activation of glial and immune cells. So glial cells are there in CNS, immune in periphery and CNS, and because these cells gets activated because of chronic scratching or chronic irritation to the skin, they are going to release a lot of inflammatory mediators. And they will further increase the itching. Increase of excitatory activity in sensory neurons. So the neurons which carry the signal of itching, their excitation increases. They get easily excited. That can be because of increased receptors or increased transmission through secondary messengers. A lot of things can happen at the level of neurons, but eventually they're just getting excited a lot or more frequently. Fourth is central sensitization. Now what is sensitization? That means the CNS or the spinal cord can be easily excited by the itch signal. So normally you have all those negative negative control, but in the absence of those negative controls, these areas, centrally located areas in the CNS, remember we discussed these areas in the part 1, the centrally located CNS areas or the itch receptors, they get easily excited by the and on repeated excitation of these receptors, they become kind of sensitized. They become easily the cycle could be easily started, and when that happens, the chances of this developing into a vicious cycle increases. Fifth is reflex action. If we keep on doing something continuously for a long duration of time, it becomes a reflex action. Okay, for example, if we are driving or swimming, it becomes reflexively ingrained in our brain. Similarly, if we keep on scratching one area, and this is one of common thing that we see in disorders like lichen simplex chronicus, that it becomes a it becomes reflex. And if you're not paying attention or you are sitting idle with no stimulus from outside the environment, you may tend to subconsciously scratch the area, and this further leads to release of all the mediators and activation of free nerve endings, causing the itch scratch cycle. Sixth is soothing sensation of scratching. Remember, in the part 1 of the video, we discussed about the precuneus center in the CNS, which is responsible for the contagious itch. Along with that, we discussed the substantia nigra and the striatum areas of the brain, which are the reward centers. And whenever we scratch, there's release of somatostatin and dopamine, and this leads to a better feeling, a better, a happy feeling. And this soothing sensation is very much rewarding for us. So because of that, we just keep on scratching and we become kind of addicted to scratching. Itch sign materia. Itch sign materia means itch without any lesion. So you don't have a lesion, but there's some kind of irritation going on the skin, and to relax that irritation, a person may start scratching, and because of that, the itch scratch cycle can start and propagate. Cross sensitization. Now let's say you have any issue with your nerves or any kind of neural pathway issues, and now pain is being interpreted as itch, or the fibers that carry the pain sensation, as we have already discussed in the part 1 of the video, that pain and itch have a good relationship. So the fibers that carry pain can also carry the itch sensation, and because of cross sensitization, let's say whenever you feel something hot, you might start itching the area, or you feel something cold, you can start scratching the area also. So this kind of cross sensitization in between the different nerve fibers carrying different sensations can lead to starting of itch scratch cycle. Okay, so we have discussed 8 reasons for the starting of itch scratch cycle. So because of this, you can easily write any short note on itch scratch cycle. Now let's discuss the cause, or not exactly causes, but the presentations under different context. The first context is itching in elderly. So itching in elderly, it's a very common complaint, especially more than 65 years, and after 65 years, it's mostly because of dryness of skin. Pruritus ranges from about 11 to 78%. Okay, and that's a huge number. What I will discuss is, I will not discuss disorders like diabetic induced pruritus or discuss about atopic dermatitis in elderly. We will not discuss when we have a definite cause. They are a topic for separate individual videos altogether. What we'll discuss in this segment of the presentation is senile pruritus. So what is senile pruritus? This is a definition which is often can be asked in your viva. Senile pruritus is idiopathic itching without a primary rash in elderly. Idiopathic means we don't know the cause. Okay, so we don't know the cause of the itching without any primary rash in the elderly. Okay, so senile pruritus can lead to secondary changes. Okay, it can lead to secondary changes like lichenification, erosions, ulcers. So these things can happen, but there is no primary rash. There is no rash before the itching. Okay, and apart from senile pruritus, we have multiple issues in the elderly, mainly skin, that can be because of atopic dermatitis in adults, somewhat like skin disorders. Liver is damaged, which can cause liver damage induced itching. We'll discuss that in few slides. Kidney damage can lead to itching. Again, we will discuss that. Psychosocial will discuss. Loneliness. If you are sitting idly post retirement, your mind can vary and it can go around, and you may start scratching one area, leading to secondary changes, leading to the itch scratch cycle. Diabetes and thyroid disorders are also common in the elderly, so they have to be taken into account. Make sure that if you are diagnosing a patient with senile pruritus, you ask about the history of diabetes, thyroid disorders, any other medications that might be taken. Malignancy. Now, malignancy induced itch is very important. If you have any itching with no apparent clinical signs on skin, and the itching is very severe intensity, and is not at all responding to antihistamines or nerve suppressants, it's a good idea to look at other signs of malignancy, or at least screen for different malignancy depending on the age group. Multiple medications that they might be taking, like statins leads to decreased cholesterol, and because of that decreased cholesterol, the skin tends to lose the kind of protection it has against the transepidermal water loss, making the skin more drier and drier. Neuropathic, age-related neuropathic, mostly small fiber small nerve fiber disease. Anemia can also lead to itching. Okay, but we'll keep our discussion restricted to senile xerosis or senile pruritus. Now, senile xerosis occurs in about 38 to 85% of patients, maybe much more than that. It's quite commonly seen in in multiple geriatric population. And I have enumerated about 8 causes of senile xerosis. That means 8 reasons why the skin of elderly becomes drier and drier as they age. And why do we have to keep that in mind before just prescribing antihistamines and emollients? Okay. First is decrease intercellular lipid matrix. Now, the upper layer of the epidermis are made by keratinocyte, and in between you have lipid. Let me just change the color. So in between you have lipid, and this is known as brick and mortar model. Okay, maybe in the future sometimes I'll discuss the process of keratinization, and it will become much more uh, elucidated or clear for you. So this is known as brick and mortar model, in which the bricks are the keratinocyte and mortar, that means the cement in between, is the lipids. So when the lipids are decreased in elderly because of age-related changes, it increases transepidermal water loss. So the water is lost from the skin and it leads to further xerosis. Second is pH changes. Remember that cholesterol with age will tend to decrease in the skin, and when you don't have lipids, you will not have free fatty acids. So when acids are reduced, it will lead to alkaline pH. Okay, so when acids are reduced, the skin pH will tend to become much more alkaline, and this leads to dryness of skin, decrease enzymatic activity, and decrease natural moisturizing substance. Decrease natural moisturizing substance. Now, maybe in the future I'll discuss this natural moisturizing substance in much detail. It includes a lot of different naturally forming substances which are responsible for good amount of water intake and to make sure that the skin is naturally moisturized. Natural moisturizing substances. Now, this alkaline pH also increases serine proteases, which further activates the PAR2 receptor and itch. This we have discussed in details in the part 1 of the video, that various proteases like tryptase from mast cells also activate PAR2 receptor, which further lead into itch pathway. Fourth is decreased activity of sweat and sebaceous gland. So under the process of decreasing hormones as we age, the sweat and sebaceous gland activity is decreased. Additionally, in female patients, you have decreasing estrogen postmenopausal. So because of that, you can have decreased synthesis of good cholesterol, good lipids at the level of skin, and the skin will get drier and drier. Immune senescence. The fifth point is immune senescence. So what do we mean by immune senescence? Immune senescence means that as the person ages, as the individual ages, the immune system is not as robust, it is not that active, and some or the other kind of problems keep on happening in the immune pathway. Now, this can lead to immune dysregulation and this can lead to autoreactivity. Remember, if immune cells are not acting properly, they can lead to increase or maybe spontaneously degranulation can happen, and it can lead to release of a lot of mediators. And what will these mediators do? They will attach to their respective receptors and will have the tendency to start itching. The process of itching will start because of this immune dysregulated cells. The sixth point is epidermal nerve density decrease. Remember, I told you that in the first part that in between the keratinocytes, you have the free nerve endings. Okay, and with time, what happens is that these nerve endings are reduced. Okay, and because of that the sensation is not properly localized and you have a diffuse sensation. And remember, when you have a weak stimulus acting over a prolonged period of time, it can lead to itch. We discussed that in the part 1, isn't it? Okay, skin disorders like herpes zoster, notalgia paresthetica, diabetes mellitus, induced skin small fiber neuropathy. These are all causes of small fiber neuropathy, and it acts somewhat analogous to the epidermal nerve density decrease, which can lead to starting of itching. Similar to notalgia paresthetica, we have the eighth reason, which is the nerve compression, which can lead to notalgia paresthetica and brachioradial pruritus, which we have already discussed in the last slide. And these are the roughly 8 causes of senile pruritus or senile cirrhosis. So you have to keep in mind what is acting properly. If it's nerve compression, we have to evaluate for that, give nerve suppressant. If it is because of immune dysregulation, maybe give histamine to counteract, okay, or topical steroids. If it is because of lipid changes, give a lipid rich moisturizer. Okay, so we need to know these things so that we can screen our patient for the cause of senile pruritus. Now, this is one pathway which is mentioned in this article, treatment of pruritus in the elderly. I will not going to spend much time on this slide. It's a complicated slide to be discussed, and there's nothing much to explain actually. It just has a lot of data. Okay, so you don't have to be scared because of the data. You just have to understand what we mean by that. You have to first divide into this dermatological cause, or if you cannot find any skin lesion, a non-dermatological cause. Then you just look at any recognizable lesion, or if it is not recognizable. If it is not recognizable, do a skin biopsy. Keep bullous pemphigoid in mind. Remember, I read that in one article that if an elderly patient comes with an intractable itch or urticaria not that responsive to antihistamine, consider a possibility of bullous pemphigoid. Maybe the patient is still in the urticarial phase. Get a biopsy, see the eosinophil rich, see if there's any blister or forming or not. And if it's more on the acral areas, you have to keep bullous pemphigoid in mind. Okay. If it is because of a dermatological cause, you give the respective treatment. If non-dermatological, you look for the neuropathic structure, any systemic causes like kidney disease or liver disease, and then also consider the psychogenic cause of pruritus like anxiety and depression. and then manage accordingly. So I will not go into detail on this slide, but I request you to go and read this article, Pathophysiology and Treatment of Pruritus in Elderly. I have pasted that URL, so you can just copy paste, get access to full text, and read this article. It's a very good article on treatment of senile pruritus. The second clinical aspect that we'll discuss now is biliary cholangitis, or anything which will lead to increased bile salts. Remember that in chronic bile salts, in chronic liver issue or chronic liver damage, or if there's any kind of compression of the biliary radicals, it will lead to increased bile salts getting accumulated and coming into the circulation. These bile salts, when they get deposited in the skin, it can lead to itching. This has been proven by the fact that intradermal injection of these bile salts leads to starting of an itch response at that site. Okay, so anything which leads to accumulation of bile salts in blood and serum can start itching. The major receptors which are involved in that is the GPRS receptors, which are majorly the receptors on sensory neurons, and a new branch of receptors known as farnesoid X receptors, which is present in skin, liver, and brain. Okay, so these are responsible for carrying the itch sensation when it is initiated by bile salts. Okay. Additionally, TRPV1 receptor, which we discussed in the part 1 of the video, the capsaicin receptors. We have discussed that in somewhat detail in the part 1. Go back and listen to it. So these are the receptors which gets activated by the bile salts, and you have starting of the itch response. The treatment is given, the cholestyramine is the drug of choice to treat any pruritus which arises from accumulation of bile salts. What it does, it sequesters bile salts. It catches bile salts and traps it, and then removes it, makes it more water soluble, so it goes out from the through the urine. Okay, so it sequesters bile salts and removes them. Additional things that can be tried is phototherapy. So, for example, in physiological jaundice, phototherapy is one of the treatments. So, what happens is, under the influence of phototherapy, the bile salts become more water soluble, and the kidneys filter them out. Okay, so there have been few individual case reports in which narrowband or broadband UVB has been used as a phototherapy, has been used to remove bile salts. It has also been found that high dose vitamin D or even normal dose vitamin D can reduce bile salt synthesis. Mainly, I think it's because of the rate determining step enzyme inhibition. I don't remember the enzyme name, but if you want to know, maybe you can search, take it as a homework, and learn more about what does vitamin D do to the skin. Most of the time, what we give to the patients of bile salt induced pruritus is ursodeoxycholic acid. The counterintuitive part is that ursodeoxycholic acid is itself a type of bile salt. So how does giving a certain bile salt decreases bile salt induced pruritus is still a matter of research. We don't know particularly how it happens. One of the implications is that increased quantity or increased concentration of bile salt leads to some kind of negative feedback, and the bile salt pathway is suppressed, while ursodeoxycholic acid is not able to cause this kind of itching pathway. So that's one of the thought processes. Okay, so we have discussed increased bile salt induced pruritus. In this diagram, we are just going to recapitulate what actually happens. Cholesterol gets converted from the CYP enzymes to different bile salts. These are the primary bile salts. That means the bile salts formed in the liver, and then through the enterohepatic circulation, they get secreted through the pancreas duct, and everything gets secreted into the intestine, where they are further modified to form second degree bile salts. Okay, these then activate the TGR5 or the GPR5 which we discussed, and upon activation at the end of nerve endings, which is the cutaneous nerve endings, they lead to starting of the itch cycle. So what happens is that when liver creates the first degree bile salts, it gets secreted into the intestine, where they are absorbed and put into circulation, and through blood they go into all these skin receptors which get activated by the bile salts, leading to starting of the itch impulse. And this pathway we have discussed in the part 1 of the video, that from here it goes to spinal cord and to the brain. Okay. Additionally, the FXR or the farnesoid receptor is also implicated, and that it leads to, by an unknown mechanism, it leads to the itch pathway. So these are the areas of current research. Now the issue arises that even in end-stage liver disease, when the amount of bile salt is very high in the circulation, the itch intensity is not that high or does not change with the level of bile salts in the blood. Okay, so end-stage liver disease, there's not much itch. Bile salts levels are not related to the levels of itch because it can be because of any receptor mediated itch. That means even a small amount of bile salts can activate the receptors to significant extent, and it can lead to significant itch even when the concentration of bile salts is low. This additional theory known as autotaxin or lymphophosphatidc acid theory. So LPA is lymphophosphatidc acid, which is a potent itch mediator. Okay, so what happens is that it has been found that serum levels of LPA are higher in patients who have cholestasis, and it correlates with itch intensity. Remember that lysophosphatidic acid correlates with itch intensity. But in other causes of pruritus, LPA is not seen. So it is a matter of great concern and research that LPA, not concern, matter of research, that LPA levels are found to be increased in cholestatic pruritus, and it can be because it is a mediator of cholestatic pruritus. So it has been found that maybe in patients who are complaining of bile salt induced pruritus, we can find the levels of LPA, and then it can have a good prognostic value in itching. Autotaxin can serve like a tryptase-like fashion and activate PAR receptors, and further which it can lead to itch. So this is a theory which has been given how bile salts can also, another mechanism through which bile salts can cause itch. Now let's discuss the third parameter, which is uremic pruritus or kidney disease induced pruritus. Now, one thing different from liver damage induced pruritus or cholestatic pruritus is that end stage renal disease is associated with a lot of itching. We have already discussed in the last slide that end stage liver disease, the itch is not that much, not that increase as much as we expect. But end stage kidney disease, the itch is significantly high. Okay, so the itch is significantly high. Okay, so this has led to a belief that, not belief, it has led to the discussion that the uremic itch occurs by a different pathway. Okay, so it also depends on the type of hemodialysis the patient is on. In end-stage renal disease or when the kidneys are sufficiently damaged, the patient undergoes dialysis. And if it is peritoneal dialysis, then the prevalence is roughly about 25 to 62%, and it is seen more in hemodialysis. Okay. This diagram just show that the different changes that happens in end-stage renal disease which can lead to itch. If you want to study the uremic pruritus and management and physiology in detail, you can go and read this article by MJ et al., which is Uremic Pruritus, Pathophysiology, Clinical Presentation and Treatments. I have the link, the URL in the description. So in end-stage renal disease in skin, we find that the skin moisture is decreased substantially. There is also increase in inflammation, predominantly mast cells, which may release histamine causing itch. There is increased concentration of divalent ion, and divalent ions further increase the action potential, or they excite the free nerve endings, leading to starting of the itch pathway. Okay, while in systemic mechanism, so we have discussed what happens in skin. There's loss of moisture, there's increased inflammation, there's increased activation of free nerve endings. In the systemic pathway, the Th1 response is increased. There is increased C-reactive protein, which is a marker of inflammation, increased interleukin 2, 6 and 31, and this can also lead to increased itching. All of these processes can activate pruritoceptors. Pruritoceptors, remember in the first part of the video, we have learned that this is another name for free nerve endings, or the receptors present at the free nerve endings. So when these are activated, it can lead to starting of the itch pathway. Additional system which is implicated is the opioid system. So if when kidneys are damaged, the opioids are not excreted. Different mechanisms that opioids can be increased. If the opioid which is increased in the system acts on the mu receptor, they will be increased in itch. Okay, and if it acts on the kappa receptor, they will be decreased in itch, suppression of itch. So we have discussed that in detail in the part 1, so I'm not going to detail much. Okay, and when through the pathway the impulses gets transferred to the first degree, second degree, and the third degree neurons and reaches the brain, it can lead to behavioral change, emotional change, also opioid system alteration acting at the level of CNS, and psychogenic pathway leads to further solidification of the itch cycle, leading to an itch scratch cycle in patients with end stage renal disease. Okay, let's move forward. So we have discussed that in uremic pruritus we have low skin moisture, low stratum corneum hydration. That means the water levels are decreased. The divalent ions, calcium phosphate products, hyperparathyroidism because of kidney damage, or uremic nephropathy. These are all implicated things in uremic pruritus. There's also immune dysregulation. That means CRP is increased, histamine is increased, inflammatory cytokines like interleukin 2, 6, 31. 31 is found to be increased in mice models, so that also increased. Remember that interleukin 31 is responsible for chronic itch. Chronic itch predominantly seen in patients of atopic dermatitis. Okay, so these are also implicated. Additionally, we have low kappa opioid receptor expression in patients undergoing dialysis. Remember, whenever kappa opioid receptor is not that much activated, the itch is not suppressed and you can have increased itching in uremic patients. Potential therapeutic option for uremic pruritus include that we have to first identify what is wrong with the patient. I would suggest that we should start with good amount of moisturizer to take care of the water loss and decrease hydration of the skin. Maybe give topical steroids. We are talking about topical steroids, not systemic steroids. Topical steroids if we suspect increased inflammation as a cause of itching. Pramoxine is a locally acting anesthetic agent which is now very popular in giving as an emollient or a topical application that has been also used. And most important is treatment of underlying disorder. Remember that if itch is because of a kidney issue, the quicker the kidney issue is resolved, the quicker you get respite from itching. Phototherapy also can be started. Remember that narrowband UVB has a systemic immunosuppressive effect. Okay, maybe in the future we'll discuss when we'll be discussing phototherapy. Gabapentin and pregabalin stabilizes the excitation of nerve endings. They don't allow the nerve endings to get excited that much, and because of that, they can also be used in treatment of itching. Kappa opioid receptor agonist, if I remember the correct name, it is nalbuphine, and we have discussed that in part 1. So when you give kappa receptor agonist, it will act on kappa receptor, and as an agonist, it will increase its activity, and that leads to itch suppression. Okay. Thalidomide is a good option. Thalidomide is an immunoregulator. It decreases inflammatory mediators like TNF alpha. It is also a nerve suppressant. Okay, it suppresses the sensory activity. It suppresses the snap potentials. We have, if you want to, learn more about thalidomide in detail, there's a separate video. Look under the playlist leprology or leprosy, and you will find that I have discussed thalidomide in detail. So thalidomide, one of the effects of thalidomide is sedation and decreased nerve transmission. So that can be easily utilized in cases of neural mediated itching. The fourth aspect is psychogenic pruritus. This is also known as functional itch disorder. That means there is a psychiatric cause to itch. So a diagnostic criteria or a criteria that may help us to implicate a psychiatric cause to the cause of itch in our patient is given by the French psychodermatology group. Okay, and the name is French psychodermatology group criteria. So in that you have a compulsory criteria and B additional criteria. Compulsory criteria means all three. There are three aspects of compulsory criteria and all three should be present. There should be localized or generalized pruritus. Of course, if we are diagnosing psychogenic pruritus, itching has to be there. The itching has to be chronic, that means more than 6 weeks, not acute. and there should be an absence of any other somatic cause. Somatic means organ damage, neural damage, any skin disease which might be present, so they should be absent. Additional criteria includes 7 parameters, and any 3 out of those 7 parameters should be positive. The 7 parameters are chronological relationship of pruritus with psychological setbacks. That means if the patient feels any kind of psychological uh, hampering of their behavior, let's say a sudden stress has come, or a prolonged stress is there, or loss of a loved one, or financial losses, or anything, if the itching has a temporal correlation with that loss, so that's one parameter. Other parameters, variations in intensity associated with stress. That means more the stress, more the itching, less the stress, less the itching. Third parameter is nocturnal variations. Maybe you have increased itching during the night when the brain is not that occupied. Fourth parameter is predominant during rest or inaction. Again, when you remove all the excess stimulus the environment has on us, the brain decides to act on even the subliminal or subclinical stimulus, most probably itching. Okay, so these are 1, 2, 3, and 4 parameters. Fifth is associated with other psychological disorders like depression, schizophrenia, okay, delusional parasitosis. Sixth is pruritus improved by psychotropic drugs. That means you give drugs which act on psychological or psychiatric pathways, and the itch actually improves. That's another parameter. Pruritus improved by psychotherapies is the last parameter, which includes CBT, chronic behavioral therapy, counseling, discussions, and all that. Because of that, if the itch improves, there's insight. So that's another parameter. So 3 out of 7 of these parameters should be positive. Okay, now this I will not go into details of it. Looks very complicated, but what this picture is trying to say are the different mediators of itching. So we have discussed some of these mediators in very much detail in the first part. If you want to listen to all of these details in very detailed method, or understand each and individual this mediator for pruritus, I would request you to go and read this article, Chronic Pruritus in the Absence of Specific Skin Disease, an update on pathophysiology, diagnosis, and therapy. Okay, and the focus is more on mediators, because they want to look at when the patients present with the complaint of itching, but we are not able to find the cause. Okay, so this includes mediators like acetylcholine. I'll just enumerate the mediators. So acetylcholine, CG-related peptide, neurokinins or substance P, gastrin-releasing peptide. Remember, first itch-specific neurotransmitter. First itch-specific neurotransmitter. Okay. Corticotropin-releasing hormone, neurotrophic growth factors, nerve growth factors, endocannabinoids, endovanilloids, and then they act on TRPV1 vanilloid receptor. Remember. Opioids, kallikreins, histamine, prostaglandin, leukotriene. These are all different mediators apart from histamine, and all different mediators which works on different levels. So we have also discussed the sources, where they start from, and function, that what do they do in the itch scratch pathway. So I will not go into detail. What I'll do is, maybe I'll just remove this annotations, and you can take a screenshot, but I will really request you to go and read the full article, full text article. You'll be able to understand a lot of good things about different itch mediators. And trust me, if you go through these two videos, part 1 and part 2, you can read pages and pages, reams and reams about the itch pathway. This is another such of this table, and I will not go into details. It just means that what all information should be collected from a patient's history. That means if a patient comes with the complaints of itch, you should ask about work and leisure activities, travel history, personal family history, any history of injury to the spine, okay, mental state, personality changes. So it's a good idea if you can just go through the article and just read it once, so that you have just some of the ideas that what you should ask. Remember, if you can to some extent precisely locate the focus of itch, you will be able to treat your patient much better. These are those patients in which histamine doesn't seem to work. Sorry, antihistamines are not that good. They don't seem to work clinically, and they are very disturbed and depressed, and they are actually lost all hope. So if they come to you and by asking questions, by evaluating, by getting into the depth of the discussion, if you can find the focus of pruritus, you will be easily able to handle this kind of pruritus. Okay, if you think, for example, if you think that pruritus is because of damage to nerves, you can easily start nerve suppressants like gabapentin, pregabalin, and the patient will thank you when the itch is somewhat resolved. This flowchart I've taken from Bologna, 4th edition Dermatology, Chapter 6, Pruritus and Dysesthesia. It's on page 111 and it's a very simple flowchart. Okay, so patient presents with complaint of itching as a chief complaint. You take a thorough history, complete skin examination, and also look at the lymph node. Infections and malignancies can easily be ruled out. If you find an identifiable skin disease, you treat the skin disease or at least give the symptomatic treatment of itching. If you don't find any skin disease per se which might be causing itch, you look at the localized or the regional unexplained pruritus or generalized unexplained pruritus. For example, if you find the skin disease, treat the skin disease or give symptomatic relief. If you don't find the skin disease, you divide it into localized, that means one area is affected, or generalized, the whole body is affected. If it's localized, you consider neuropathic itch or some kind of nerve trunk involvement. If it is generalized, you consider renal or hepatic issue, early bullous pemphigoid or dermatitis herpetiformis, malignancies like lymphoma, endocrine disorders like thyroid disorders, diabetes, anemia, and or a psychological cause. So this flow chart from Bologna, and Bologna is the best textbook, highly recommended. Bologna is extremely well when it comes to explaining the basic concept. It doesn't go into detail. Rooks goes into details, but Bologna is one of the best books if you want one Bible for dermatology. Not Bible. Bible is Rooks. I would say Gita of dermatology is Bologna. Okay. So this flowchart simplifies it to such an extent that if you can remember and retrace or repeat this flowchart in your exams, in your answer sheets, trust me, this flowchart will lead to a lot of marks, because the moment the examiner sees this flowchart, they know that you know what you're talking about. You're not just writing anything, you know what you're doing. So with that, we end this presentation. The reading recommendations, I would suggest that you read the Uremic Pruritus one. It's a very good article. The Chronic Pruritus in Absence of Skin Disease is very good article. And the Bologna chapter number 6, Pruritus and Dysesthesia. You read this article. You read this chapter, this particular chapter, very good chapter the Bologna has written. I have recommended one more chapter, I think chapter 5 in the part 1 of the video. Read these two chapters and your concepts about itching would be very clear. And I have taken data from these two chapters, multiple articles, and I've created this video. And I think you don't require anything more at least at the level of residency to know more about itch and how to control itching. Okay, and just go through this part 1 and part 2 of these videos. Go back to part 1, see, and try to correlate and attach what we speak in part 1 and what we say in part 2. We kind of make correlations so that you're able to understand the concepts much better. So with that, I'll finish this presentation. This is the part 2. The part 1 is available. I'll be uploading both of these videos simultaneously. Remember that if you could localize the focus, the cause of itching in your patients, you can easily stop itching. You can easily control itching, and the patient would be much thankful to you that you are able to control the itching significantly. Maybe other doctors or other practitioners are not able to control that itch, they're not able to understand what is happening, and you are the one who makes such a good difference in the patient's life. Okay, and instead of just pumping 4 times a dose, 5 times a dose, significant sedative antihistamines, we must know that there are a lot more mediators apart from histamine, and other drugs should be considered in that cases. Okay, so I hope that if you go through the part 1 and part 2 of the video, go at your own pace. You don't have to rush through these videos. You can slow down as per your wish. See them in different segments. I have the description labels attached, so you can see one segment a day, 2-3 segments a day. Listen to it while walking, and you will listen to it at 1.5x the speed. I highly recommend you see my videos at 1.5 times, especially when you're seeing them second or third time. Okay, so it becomes easier for the brain to recapitulate when you hear and see things visually and audibly. Okay, in the meantime, you can write me an email on my email ID, any suggestions, newer topics, any criticisms, constructive only. You can mail me, or you can just comment your doubts, suggestions, queries, any questions, any particular concept you want me to go into detail and explain properly. When I make these videos, I learn a lot which I had not had enough time to learn during my residency, but now since I'm a bit free from the academic aspects, I would like to read more and more and make things simpler for residents to understand. We don't have much resources for the postgraduate residents, and my duty is to make these things simpler to understand and create a good resource for the residents to actually learn things, which is very important for them to understand as dermatologists. And also it becomes very academically important when questions and short notes are asked on these topics. Okay, so without further ado, adios, bye bye. I'll end this presentation. Watch both of them together, both of them separately, part piece by piece, not an issue, at your own pace. Slow it down, fast it up, doesn't matter. But trust me, after watching volume 1, the part 1 and the part 2 of the videos, you will understand what is there to understand about itching. Okay, so with that we'll end. Bye bye, enjoy your weekend.